until the end for questions and discussion. So at this point, I'd like to turn to our second presenter, who is Lindsey Peterson. As I mentioned briefly, Lindsey is also a student in Naomi Goldstein's lab, so we're getting our full due from that lab today. She's actually in the JD PhD program, which is one of the programs that we have in the Department of Psychology here that actually results in someone's finishing up after 7 years with a law degree and a PhD in psychology. And we're pleased to say that unlike previous years, when it used to be that people had to go out to Philadelphia for the part, we're now working with Drexel's Law School, so the commute is not quite as bad as it once was. So Lindsey's a sixth-year student in that program. Her clinical and research interests are in forensic psychology and in serious mental illness. She's worked on Miranda rights comprehension projects, false confessions projects, and juvenile justice interventions. Her current dissertation is on ultimate issue opinions, forensic mental health reports, and her topic today is mental health and the system. Lindsey.
Thank you for that introduction. So as Kirk said, I'm in the joint program, so I kind of think of everything I do as kind of interdisciplinary because I'm involved in both law and psychology. So today I'm actually going to focus on a project that has been going on since I started at Drexel, and that's the juvenile justice anger management intervention. And I've kind of been involved in it in a variety of ways from the beginning till now, where we're evaluating outcomes. Okay, so first I'm going to give you a little bit of background on why we decided to develop this program. So female juvenile offenders represent a growing segment of the U.S. population, specifically juvenile justice, and they're the fastest growing population within the system. In particular, they make up more than 25% of all delinquency determinations in the United States, and this number has tripled over recent decades. We've also seen that girls within this system exhibit high levels of anger and aggression, but that this hasn't really been dealt with in research or with treatment. And once they're in the system, youth are often mandated by courts to actually complete some type of treatment program, specifically anger management. So we're finding that girls are getting into the juvenile justice system at higher rates. They're having these high anger and aggression levels, but there's no treatment that's designed specifically for them. Okay, so to address the clinical and legal needs of female juvenile offenders, we looked to see what other programs were out there, and we found the Coping Power program. And this program specifically reflected the literature on childhood aggression, and it focused on skill acquisition, so teaching skills that children could then use in other situations. And this program was found effective in reducing aggression in other youth populations. So we decided to use the Coping Power program as a model for JAM. And in doing so, we had to make some adaptations because this was designed for childhood aggression. We're talking about females who are adolescents, so an older group. So we needed to make sure that it was developmentally, culturally, and gender appropriate, and that we were able to use techniques to manage the behavior that were effective within the juvenile justice setting. So we had to work within the limits of the facilities. Okay, so now I'm going to give you a little bit of background on the conceptual model we used to develop JAM. So as I mentioned earlier, the treatment was designed to reduce the high levels of anger and physical and relational aggression within this population. We also were looking to reduce mental health symptoms that were resulting from these high levels. The Coping Power program that I mentioned earlier had focused on emotion regulation, social problem solving, and cognitive restructuring of hostile attributions as the ways to see these outcomes in reducing anger and aggression. So we kept them as the mechanisms of action for JAM. And we were also hoping that these changes would result in long-term outcomes the study that we conducted, we had 75 girls who were enrolled, and for a variety of reasons, including withdrawal from the study or leaving the facility early, we ended up with a total of 57 girls, 29 in the treatment jam condition, and 28 in our control treatment as usual condition. Girls who were 18 or older were consented to participate in the study, and those who weren't, we sought parental consent, but if that wasn't able to be obtained, we used a waiver and participant advocate procedure. We had assessments at pre-test, post-test, and 6-month follow-up. And today I'm really just going to focus on the pre-test and post-test. We haven't really evaluated the 6-month follow-up results yet. So here's a little bit about JAM, the treatment itself. So JAM's a 16-session manualized group treatment. The treatment occurs 2 times a week, and each treatment session lasts approximately 90 minutes. And this goes over the course of 8 weeks. It's facilitated by 2 group leaders, and it focuses on using a cognitive behavioral framework to teach cognitive restructuring, skills training, and problem solving. Generally, there were between 4 to 6 girls per group. So now to just talk about some of the results we found so far. So when we looked at the relationship that treatment had on anger and physical and relational aggression, we found that JAM resulted in decreases in all of these outcomes. Specifically, that it reduced anger, physical aggression, and relational aggression. And what we saw was, as previous research had found, we saw high levels of anger and aggression among all our participants at baseline. But following treatment, we saw that girls who were in JAM had significant reductions in anger and aggression, but those who were in the control or treatment as usual group, their levels actually stayed the same or went higher. So the JAM group, we saw decreases from clinical to a non-clinical range on these measures. Next, we evaluated mental health, and we found that the treatment didn't have a direct effect on mental health symptoms, but in reducing anger, we saw reductions in symptoms as well. So what we evaluated most recently were our mechanisms of action, or how we thought JAM would achieve the outcomes we saw. So we evaluated emotion regulation, social problem solving, and cognitive restructuring of hostile attributions. And we looked at these in the context of only our short-term outcomes, not on recidivism. So first, we evaluated the relationship between the treatment, emotion regulation, and anger and aggression. And we found that emotion regulation was a significant mediator for anger, and then subsequently relational aggression. Now, I'm not going to go into all the stats behind this, but there were multiple measures that were used, both for evaluating emotion regulation and relational aggression, and only one of these actually came out with a significant finding. So we think that this finding may actually be due to a type 1 error, and we think that this result might actually show something meaningful. Next, we looked at the relationship between the treatment, social problem solving, and then anger and aggression, and we found that social problem solving was not a significant mediator. And finally, we looked at the treatment, cognitive restructuring of hostile attributions, and then anger and physical aggression. Here we found that there was a simpler path straight from treatment to hostile attributions to physical and relational aggression that was significant, but cognitive restructuring here didn't reduce anger. It just resulted in reductions in aggression. So this may indicate that changes in hostile attribution bias impacts aggression, but not the feelings that are associated with anger. So, in sum, JAM so far is the first treatment of its kind to directly address the needs of female juvenile offenders, and our results suggest that it is effective in reducing anger, physical aggression, and relational aggression. And what we found so far is that we really don't know exactly how it's working at this point. Only hostile attribution bias was supported as a mechanism of action, but the other 2 proposed mechanisms of action were failed to be supported, and this might be due to some issues with measurement. So the measures we used might not have accurately measured the constructs we were intending to, but we need to look further to see what's going on, because we are seeing these positive outcomes. We're seeing reductions in anger, we're seeing reductions in aggression, and we want to try to make the treatment as strong as possible by focusing on those core components that are effective. So with that, we need to further explore what else is going on with JAM and look at our long-term